Good afternoon. My name is Dr. Jesse Morse, and I'm a sports medicine doctor here at the Osteopathic Center in Miami. So let's talk about a relatively common injury that occurs on the back part of the heel or of the foot that we call Achilles tendinitis or Achilles tendon injury. Now, the nature of the Achilles tendon, it essentially comes off of the calf and tapers into the form of a tendon. So as you see here, the back of the heel, you can see the actual tendon coming down and inserting into the bone. Now I'm going to take it off because I have the ability to do that with this. You can see a little bit of a fat pad underneath it. And then if you were to spin it around, you can actually see the muscle which turns into a tendon, that little white junction, and then this is the tendon. So if you look, it inserts down here into the base of the heel, and the bone is right underneath it. So this is a relatively common injury, secondary really due to the poor blood flow in this area, predominantly in this middle area right here. The bottom part has a fantastic blood supply. The top part has a good blood supply, but there's an area in the middle that doesn't have a good blood supply, and that's usually where we get our injury because if it tears down here, it will heal. If it tears up here, it will heal. But without good blood supply, it's not going to heal. So you have these little micro tears. This often happens in jumpers because they're constantly jumping, and this thing's having to work overload over and over. Some people who have footwear that can rub this can also irritate this tendon. Insert, what we call insertional, meaning where the tendon inserts into the bone, is probably the most common location, at least for tendinitis. For an actual tendon tear or partial tear, it's usually at that what we call that watershed area, that area that doesn't have a good blood supply, kind of in the middle here. So a lot of people will experience this over the course of their lifetime. There's what we call a dichotomy. So there's people in their teens and 20s that will have an irritation, and then it usually comes back around 40s to 50s. Those are the kind of the two age groups. You can get it whenever you want, but those are usually when it happens the most. Now, on exam, you're going to have significant tenderness at this site, and usually there's one area that hurts more than others, whether it's at the insertion point where it attaches to the bone or more in the middle of the tendon. It usually doesn't hurt as it goes up towards the calf. It can, it's just not the most common site. Usually I would say in the middle here is one part, and then where it inserts into the bone is another part. So what are some of the most common ways to treat this? So the first thing is diagnosis. You want to see what are the different options for actual injury. So you can have tendinitis, which is acute inflammation or irritation of that tendon. If that calms down, you're good. If it doesn't calm down, then you're going to have to rotate. It's going to continue to progress, and that will become what we call tendinopathy. And that means that the tissue fibers of the actual tendon are no longer their normal structure. So they're disorganized and they're weaker. That's going to lead to wear and tear, and it's going to make that tendon weaker and higher risk for actual tear. You can have a partial tear, like thinking of ripping a piece of rope a little bit, but it's still structurally intact. Or you can have a full thickness tear, which basically means it's now in two pieces instead of one. Now, the issue with the tendon is that you really can't do much with your foot without this tendon, because essentially what its job is to pick up your foot. So if your tendon is irritated, you can't walk because you're going to trip. You're going to constantly trip over your foot. So when we look at our model here, without the tendon, you're basically going to trip on your toes. So you need the tendon to fire to pick up your foot. So when someone has a tendon injury, instead of walking like this, they're going to walk kind of like this to prevent the toes from clipping on whatever they're walking on. The initial would be treatment would be kind of shutting this down. You can use anti-inflammatories like ibuprofen, Aleve. You can use ice. A lot of the times I will put someone in a boot for a short period of time, a week or two, to kind of give this thing a break. If you want, you can use crutches or something like that. It's a little extreme in my opinion, but you can do it. If you want to actually treat this, then we're starting to talk about different options for therapy. So you have home guided therapy that you can do on your own if you're going to do it. You can then do formal physical therapy where a therapist actually works you through a protocol depending on where your tendon's at, how it's responding to the maneuvers you're asking it to do, and kind of going from there. Then you have injections. So this is not an area you want to do a steroid injection. That's a boo-boo. We don't do that. Why? Because if you inject steroid into this area, you're dramatically increasing the risk for it to rupture. And even though it may feel better, structurally it's weaker, and that's not a good idea. So this is not an area where you should inject steroids ever. That leads us to different types of injections that are not steroid based. So we're thinking prolol therapy, which is essentially sugar water, and then you can add some different levels of regenerative medicine. So you have PRP, which is the blood one. You have bone marrow. You can have some different types of amniotic tissue allograft or umbilical allografts. So we have a couple different options that you can actually go in there and structurally re-strengthen that tendon. Now, do these work? Very much so. Is the injection easy? No. This is a painful injection, but it works. So you bite the bullet for a little bit, and then the results are usually really good. Now, if it's a full thickness tear, you don't necessarily have to have surgery, but it really depends on your goals. If you want to be active, it's going to be a little hard to be active and have a full thickness tear. If you're active, and especially if you're a professional, you almost always have to have a surgery to really repair it. And here's how the surgery looks. So the most common one they're doing nowadays is called a PARS. So a PARS, it basically they're gonna put some guard wires over here and over here, and essentially strengthen and tie this whole area together. We used to think this was just a death wish for any professional athlete. Their career was over after sustaining a full thickness Achilles tear. Now it's not. The data's getting a little bit better, and guys are being able to come back and perform at pretty respectable rates on the field. So the data is not as bad, and they're doing better. But this is a very hard injury to come back from, usually a close to a year, sometimes more. So usually you want to do everything you can to prevent needing surgery beforehand. Surgery is that year-long process. So ideally you do everything you can to prevent having surgery. I hope you found this helpful. If you have any questions, we'd love to hear them in the boxes below. Be sure to subscribe to the channel for some of the other videos that we're recording. Take care.